Hello, a very warm welcome to World Day of Regional Anesthesia and Pain Medicine. I hope you're all having a fantastic day. My name's Nuala Lucas. I'm an anaesthetist working in the UK. And today I'm going to be telling you about some new developments in obstetric anesthesia that I hope will be useful for your practice. To try and frame this conversation, I want you to think about a patient called Sarah. She's 32 years old, having her first baby. She's got a slightly elevated BMI and mild preeclampsia. She had an induction of labour at term, but unfortunately her baby became distressed and she's proceeding to have a caesarean section. And the areas that I want to look at are pain during caesarean section under neuraxial anaesthesia, airway management during obstetric general anaesthesia, and post-caesarean section analgesia. Now, intraoperative pain during caesarean section under spinal or epidural top-up remains a critically important topic for us as anaesthetists, and even more importantly for our patients. And this very nice systematic review and meta-analysis published last year in Anesthesiology aimed to provide an accurate estimate of the incidence of patient-reported pain during caesarean section under neuraxial anaesthesia. They looked at more than 2,000 studies over a significant time period and ultimately included 34 from more than 20 different countries. Now, they found that the pooled incidence of patient-reported pain was 17%. With spinal anaesthesia, it was about 1 in 7, but with an epidural top-up, it went up to as high as 1 in 3 patients. Now, before I summarise my thoughts on this, I want to consider another manuscript. It's an unusual manuscript that aimed to assess the impact of patient-anaesthetist interactions, including unconscious attitudes, and whether these might influence the use of adjuvant intraoperative analgesics and anxiolytics during elective caesarean section under spinal anaesthesia. What these authors did was a prospective observational study in more than 500 patient anaesthetist pairs. They had a fairly standard spinal anaesthetic with a block tested in the usual way. There were no written protocols for how the anaesthetist should give adjuvant analgesics or anxiolytics. But the anaesthetist was able to give as they saw what they preferred to do. And how they assessed the impact of patient anaesthetist interaction was to use custom transference or counter transference questionnaires. So what are these questionnaires? Well, countertransference describes a clinician's emotional response to the patient. I felt close, attached to the patient. I felt protective. Communication felt easy. And transference describes the patient's feelings, expectations that are projected onto the clinician. I felt the anaesthetist understood me, cared about me. I trusted them. And then the authors of the manuscript captured the results of these questionnaires on a Likert scale to try and get objective results. And then they looked at the results and tried to see if there was any association with whether the patient received intraoperative analgesics or anxiolytics. So what did they find? Well, 9.8% of patients reported intraoperative pain, consistent with the results of the systematic review. 22 patients received intravenous supplementation of any sort. Interestingly, anxiolytics were given 4 times more than analgesics. And remember, we're careful in guidelines, and I think when we're teaching, to say that it's not anxiety, it's more often more likely to be pain that a patient feels. There was a lower odds of supplementation when the patient had a higher income or shared a language with the anesthesiologist. And critically, anesthesiologists who felt more attached, close to their patients, were more likely to give medication. Or put another way, anesthesiologists who liked their patients were more likely to give medication. So, how can we interpret the findings of the systematic review and the questionnaire study in terms of our own clinical practice? Well, first up, I think we need to provide much improved preoperative information. And I think in particular, we need to be honest about the limitations of our epidurals and spinal blocks. They're very effective at blocking pain, but they're not as effective at blocking pressure and touch sensations. Now, we sometimes say to patients, well, it's just pressure, it's just touch you're feeling. But if somebody grips your hand really firmly, that's not very comfortable. It may not be pain in the same way as a sharp object is, but it's still pain regardless. And I think we need to be honest with patients about what to expect. I think we also need to reassure them that if they feel pain, tell us and we will treat it. We must be careful not to undertreat pain. If the patient reports pain, we need to stop, acknowledge it, inform the surgeons, and use a fast-acting intravenous analgesia and avoid defaulting to its just anxiety. And of course, if that's not successful, we should be providing general anesthesia. And finally, I think it's important for individual units to measure and learn, to take a look at your own local rate of supplementation for caesarean section under neuraxial techniques. And if the rates are increasing or higher than you might have anticipated, what can you do to try and examine this and bring the rates of intravenous analgesic supplementation down? Now, next, I want to talk about airway management during obstetrical anesthesia, general anesthesia. These are a couple of manuscripts that have been published looking at the use of video laryngoscopy. The first one looking at it specifically in obstetric patients, the other one in general patients. Now, despite the fact that we worry about airway management in obstetric patients, the use of video laryngoscopy, which is very much the zeitgeist of anaesthetic practice at the moment, remains understudied in obstetric patients. And I want to tell you about this nice science letter that was published in Anaesthesia and Analgesia last year. It was a retrospective before and after single academic study looking at a period before COVID and a period of after COVID. And the primary outcome was the use of video laryngoscopy or direct laryngoscopy in obstetric patients, with secondary outcomes as first pass success, Cormack and Lahan view, and intubation difficulty. What they found was that before and after the pandemic, video laryngoscopic use in obstetric patients increased from around 23.5% to almost 72%. Interestingly, there was no difference in first pass success rates. The laryngeal view was better with video laryngoscopy, but intubation difficulty, perhaps surprisingly, was reported slightly more often with video laryngoscopy. So how can we interpret this for our practice? Well, I think the cumulative evidence is that default readiness with video laryngoscopy makes sense. The familiarity of the devices as we increasingly use them in our general practice, and critically in obstetrics, the shared view. So when you pass the tube, it hopefully into the trachea, somebody else, your anaesthetic assistant, your ODA, can confirm that the tube has been passed. But I think we have to be careful about expecting magic gains in first pass success rates just from switching devices. Video laryngoscopies aren't a panacea. And what do I mean by this? Well, we have to continue to prioritise good basic tools for airway management, effective pre-oxygenation, positioning, and a clear plan B over simple video laryngoscopic device hype. And if I had to pick out one element of these particular tools, I'd say positioning. Remember, we're often giving a general anaesthetic in a critical emergency. Everything has to move very quickly. And I think optimizing the patient's head position to really give you the best chance of successful intubation is one area that's quite often forgotten about. I think we need to acknowledge that more difficult ratings in terms of intubating the patient with video laryngoscope reflects operator perhaps inexperience and not true deterioration. And I think what this means for us is that we should be looking at perhaps the most effective VL devices to use in obstetric patients. What this study does not prove is that video laryngoscopy is superior for hard outcomes in obstetrics. It's a retrospective, single-centre study, subjective difficulty ratings with no operator experience data. Now, the final area I want to look at is post-caesarean section analgesia. We know that long-acting intrathecal epidural opioids, morphine or diamorphine if you work in the UK, provide a fantastic baseline level of post-operative analgesia, superior to abdominal wall blocks. But there continues to be some debate about the appropriate dose to use. How do we balance maintaining effective and prolonged analgesia with minimizing side effects? These two NICE studies were published in IJOA last year. The first is a prospective non-inferiority trial looking at 50 mics of intrathecal preservative-free morphine versus 100 mics of preservative-free intrathecal morphine. And what these authors found was that 50 mics was non-inferior to 100 micrograms, and they had similar side effects and patient satisfaction rates. The second study is a retrospective cohort study comparing 150 mics with 100 mics, a large number of patients, and they looked at similar primary and secondary outcomes, opioid use and side effects. They found that 150 mics was equivalent to 100 mics of preservative-free morphine in terms of additional post-operative opioid consumption. So it certainly didn't seem to confer a benefit if you use the bigger dose. But with 100 mics, you had a decreased incidence of nausea and pruritus treatment. So how can I summarize this? Well, it does seem that doses of 50 to 100 micrograms of intrathecal morphine, preservative-free morphine, combined with paracetamol and non-steroidals, appear appropriate for elective caesarean section. Now, the final thing I just very briefly want to discuss is the issue of paracetamol. And towards the latter part of last year, this received a huge amount of attention because of some quotes from across the Atlantic suggesting that prenatal paracetamol exposure had detrimental outcomes in terms of the child developing autism. Well, I can reassure you, and more importantly, our patients, this very nice systematic review has just been published within the last month. And what these authors found was that there was no association between prenatal paracetamol exposure and autism, ADHD, or intellectual disability in sibling comparison analyses. And these findings were consistent in low risk of bias studies and those with more than 5 years follow-up, supporting current guidance that paracetamol remains the most appropriate first-line analgesic and antipyretic in pregnancy when used appropriately. So how can we summarize Sarah's journey with this new evidence? Well, I think we need to be mindful that pain during caesarean section perhaps occurs more frequently than we would perhaps like to acknowledge, and it's higher with epidural top-ups compared to spinal anesthesia. We need to emphasize the limitations of our techniques in the preoperative discussion. We need to be proactive about supplementation and honest reassurance. In terms of anesthesia for GA caesarean section, well, if you're going to have to convert to general anesthesia, use a video laryngoscope. The views are better, the outcomes are similar, and training and planning for airway management still matters more than the device alone. And in terms of post-caesarean section analgesia, the optimal dose of intrathecal preservative-free morphine is 50 to 100 micrograms. If you use more than that, it's likely that you'll increase the side effects without extra benefit. Thanks for listening and enjoy the rest of the day.